Okay, so Dr. Comisar is here with us. I apologize again for the delay. Dr. Comisar is a board certified and fellowship trained orthopedic surgeon who specializes in sports medicine related injuries. He has a subsequent subspecialty certification in sports medicine. He'll be speaking to us tonight about throwing injuries in sport. Dr. Comisar?
Thank you. I'm trying to get to the presentation here, guys. Sorry. I feel woefully inept here with this from a technological standpoint tonight. Sorry. We had this working, didn't we, Heather? You can tell them all that I'm not that.
We did. We had it working and then it completely shut down. So, and there's been an issue with Wi-Fi and with some other things. So again, apologies for the delay.
I'm trying to back out of this so I can get to the share my screen part here. Okay, let's try this. There we go. Okay. So I want that. Share that.
There you go.
Is it okay? There we go. Sorry, guys. For those of you who are there, I appreciate you hanging in there with me. So I'm an orthopedic surgeon. I do sports. I'm treat problems with the knee and shoulder primarily. This time of year, we wanted to talk about throwing injuries. Thought very apropos with baseball beginning. Focus on youth sports. If you have questions, stop me either during the middle or at the end. I'll try to speed it up since I kind of took enough of your time while you're waiting on me. So our goal is to kind of talk a little bit about mechanics, just so you understand that and what role that plays, some of the developmental and adaptive changes that happen in the young youth and adolescent thrower shoulder as a result of throwing. Some of the different types of mechanisms of injuries. Some are anatomic or musculoskeletal. Some are more like environmental or sport related. And then rehab techniques maybe we can employ to help prevent that. So this is kind of a laundry list of stuff I'm going to kind of cover here. I'm not going to dwell on this too much. So injuries in youth sports, certainly participation in youth sports is surging worldwide, if not certainly domestically in the US. Baseball is no exception. Estimates roughly 9 million athletes ages 6 to 17 roughly participating in baseball. And I'm sure that number is constantly changing and likely growing. Certainly these kids are starting to play at a younger age, so they're playing more games, more practices, more tournaments or showcases. They got fall ball or sometimes winter ball, more lessons, etc. So all those like cumulative incidents or episodes, if you will, can take a toll on anybody, but certainly young developing arms. Historically, there were some figures suggested like 10% of youth sports injuries in baseball were overuse. Now we're seeing more like 70%. Sure, that's kind of hard to track, but it's kind of an interesting trend, if you will. The overall incidence in sport, the injuries quoted anywhere from 2 to 8% in baseball, resulting in 150,000 ER visits, which is interesting also because you would think those would be more like traumatic or acute injuries, whereas a lot of the stuff we're going to talk about is more just, hey, this gradual arm soreness that develops over time, as opposed to a one-time event. So why so many injuries? Likely multifactorial. We're going to talk about overuse. You know, you've probably heard a lot of that associated with youth sports. We're going to tell you why that's important in this subset of patients. Certainly poor conditioning, lack of endurance, relative muscle weakness in these athletes, be it the really young kids up to the adolescents. In some cases, muscle or capsular tightness, imbalance affecting the joint function. Mechanics are big. We're going to talk about that. I'm not I don't claim to be a pitching coach, but I can at least talk a little bit to mechanics. And lastly, poor coaching. Not all coaching is poor, but some coaches, I think, don't have the knowledge base that maybe they could or should have. And part of our job is to help educate them when we can. So bony anatomy, just a little brief review. The shoulder's a ball and socket joint, tremendous range of motion. So you can get way over your head, do all kinds of crazy things with it compared to some other joints, but it also is vulnerable to injury because of some of the stresses that go with that. The main bones are the ball part is the proximal humerus. The socket is what's referred to as the glenoid, which is an extension of the shoulder blade or scapula. That's also important with respect to how the scapula or shoulder blade actually moves or articulates with the back of your thorax or chest wall, if you will. There's muscles that control that all can play a role in throwing. There's ligaments across the front of the shoulder, the superior, the middle, and inferior glenohumeral ligament. The inferior glenohumeral ligament is particularly important kind of in that throwing or like cocked position. It kind of swings up and it almost is at like the 3 o'clock level on a clock, resisting kind of anterior translation, helping with stability of the shoulder when you're in that throwing position. The glenoid labrum. What's the labrum? Labrum's like kind of a ring or cartilage that deepens the socket. So in that bottom photo, it's kind of like the ring around the pear, so to speak. The labrum deepens the socket, so it helps a little bit with stability because the ball's much bigger than the socket. It also serves as an attachment point for those ligaments we talked about in the capsule. So again, we talked about that size mismatch. You can see the bottom left, the ball's big. The socket's small. It's kind of like a golf ball in a tee analogy. So that stability is dependent on your static restraints. The bony architecture or contour kind of helps with stability, the capsule, the ligaments, and the labrum. If any of those things are disrupted, torn labrum, sometimes capsule stretched out, ligament stretched out, that can put an increased stress on this joint. Maybe it doesn't dislocate throwing, but maybe there's a little more translation, if you will. And if you get into that situation, then the dynamic restraints, so the static restraints are the ones that are kind of, they are what they are, they don't change. The dynamic ones are kind of mobile or can change depending on the needs of the joint, if you will. So the primarily ones are the rotator cuff musculotendinous unit, which is you're seeing here on the right. So the front of the shoulder is depicted on the left. That's the subscap, kind of a powerful internal rotator. Your supraspinatus up on top, and then the back has the infraspinatus and teres minor, and those are kind of important in like slowing down or decelerating the arm. Also, that scapulothoracic motion we referenced, how your shoulder blade sits on your chest wall. You know, think about the shoulder blades on one end, but the socket's on the other. So if the shoulder blade's kind of off, it can kind of tilt the joint and has adverse effects on shoulder function and certainly throwing in this case. So when we talk about the throwing motion, there's different phases to it. There's a wind up, an early cocking, a late cocking. Whoops, I don't know why I did that. An acceleration, and then a follow through. And then in some cases, there's actually a phase they describe as deceleration, which occurs between acceleration and follow through, kind of slowing the arm down, if you will. And obviously there's different stresses on different parts of the body at each one of these phases. Here's an example from my fellowship. I was in Houston. Billy Wagner was a reliever, lefty, little guy, huge legs, and threw like 100 plus. Really was kind of had great mechanics. This is an example of him in that kind of early cocking phase where he's starting to kind of accelerate and really drive off the mound and generate his power. So throwing puts tremendous stresses on the shoulder, sometimes estimated to be up to 2 to 3 times body weight, particularly in that like late cocking. And then the deceleration phases are when the shoulder is really feeling those stresses. And it can lead to some developmental changes in that young thrower, some adaptive changes in more of a mature thrower. So the young guys are more vulnerable because they have open growth plates where those things can be, their plates can be at risk, whereas older throwers don't have those bony kind of weak links, if you will, and instead they may get changes in other parts of their shoulder anatomy. And the improper coordination of these motion segments of that pitching motion can lead to injury. So mechanics of throwing all involves the transfer of power really from the lower body, the core, to the trunk, then to the scapula, and finally to the shoulder, generating this kinetic energy. So it really relies on an efficient transfer of that energy from the trunk to the humerus or shoulder. That's why the mechanics are so important, to kind of harness that power from below the waist and shift it to the shoulder to deliver those rotational forces to the shoulder while it throws. And there's different phases. We talked about showed the phases before, but there's within those phases, there's different things that you can look at as part of the motion, whether it's the separation of hands, the foot strike, when the shoulder extremely external rotates, and when ball release occurs. And so if those specific functions happen at different phases in one person versus another, it may adversely or benefit their mechanics and their pitching motion, if that makes sense. So some of the developmental changes we alluded to, the young throwing shoulder, you get these stresses on the growth plate of the proximal humerus. You can see this X-ray on the left. There's kind of widening of what's called a physis laterally, whereas the contralateral opposite shoulder looks different. So a lot of times when we're assessing these guys, we can get comparison X-rays, and you can kind of look and see like what's happening on the right should be like the left. And sometimes when they're different, then that can lead us down a path of, hey, there's a problem here. Now, some of these patients have this widening of the physis or delayed closure, and that can be symptomatic, but sometimes it's not. The other thing that can happen, and as they get a little older, before the growth plates close, is you can get this humeral retrotorsion or retroversion, where there's actually almost like a twist to the bone, and can change how the joints aligned because of that, due to the repetitive stresses of throwing. So these anatomic adaptive changes have been identified, and one characteristics that's been discovered is really an external rotation in that cocking position. Throwers tend to have more external rotation and less internal rotation. Now, everybody is felt to have a 180-degree arc there. Well, the thrower just shifts it where they have more external and less internal. However, in a more of a pathologic setting, some of those throwers lose so much internal rotation and don't gain corresponding external rotation that there can be some functional problems with that. And it's called glenohumeral internal rotation deficit. It relates to posterior capsule tightness. And that can be a product of both some of those bony changes, but also a tight capsule or posterior capsule in this case. There's also some anatomic changes with respect to scapular movement as to how some of the muscles that control scapular stability are developed. Some can be underdeveloped, some overdeveloped, and the scapula can tilt a bit, and that can also affect your throwing motion and the ultimate delivery of the pitch. So I just wanted to give you some background on that, not get too deep in the weeds, because we're not really focusing on some of that and some of the youth pitchers, but just some things to think about when in terms of how these things come about in throwers. So these injuries can be both atraumatic or traumatic. We're going to focus on the atraumatic, the overuse problems. There's a condition called little shoulder that I'm going to go into in a little more depth. Rotator cuff strains or tendonitis, and even sometimes subtle instability if you have those capsular stretches or laxity that can maybe not lead to an unstable shoulder, but just enough abnormal movement that sometimes pitchers can be symptomatic. And that tends to happen on the older adolescent, adults, and beyond, not the kids. But certainly, just like the youth sports, the adolescent shoulders, we're seeing more problems as there's increased participation, more games, longer seasons, higher levels, more pressure to play year round, really, and also to win. And sometimes that comes at the expense of health, unfortunately. And all these things lead to these stresses on these growing, developing musculoskeletal systems. So what are some of the warning signs? The obvious things are the pain and discomfort. Hey, my shoulder hurts. Yeah, I get that. Sometimes they just have more difficulty throwing and can't quite verbalize it, especially in the younger kids. You want to keep an eye out for that. Sometimes it just can be a loss of desire to play or practice because they don't feel right. Some other subtle complaints we'll see is sometimes, hey, I can't control or command my pitch anymore. I can't control it. The velocity's gone. Other times, sometimes the mechanics get altered to try to maybe change their throwing slot a little bit so their shoulder doesn't hurt as much. They may not tell you that, but those are little subtle things that people can pick up on. And sometimes they may complain of some issues down into their hand or elbow that may be coming from higher up in their shoulder. So it's really important to listen to the young athlete. So some of these are the problems as orthopedists we deal with, the musculoskeletal issues. We talked about the rotator cuff and its importance, that glenohumeral internal rotation deficit or posterior capsular tightness that can happen, the importance of appropriate scapular function. In this case, we call it dyskinesis, meaning abnormal movement. So those can be sometimes difficult to identify, but important to address, and the subtle instability part. So when we look at these patients in the office, I'm not going to go into too much detail, but we really start and look at the whole kinetic chain. That means, what do their legs look like? What's their core? So have them do a squat, specifically this like single leg squat on the right side shows you the kid on the left has a pretty stable core. The one on the right, you can see his hips flexors or hip abductors rather are weak. His knee kind of drops in. And so when he's over the mound on one leg, if he's not strong there, that can throw off his positioning, and then in turn affects his shoulder function and ability to pitch, and sometimes leads to injury. The scapular positioning, we've kind of beat that to death a little bit. The whole range of motion arc, so if they lose internal rotation, we'll stretch that, but that's more of an issue in some of your older throwers. And then certainly looking at the rotator cuff strength. Interesting, there was a study in a physical therapy journal as far back as 2000 where there's asymptomatic throwers really were demonstrated to have weakness in both supraspinatus function, which is kind of like the empty can or like arm away from the body, but also external rotation at the side. So just because they can throw hard or they're good pitchers, whatever level, doesn't mean they necessarily are strong. So little leaguer shoulder is termed epiphyseal lysis. It's basically like a stress fracture of the growth plate of the proximal humerus. It's due to the repetitive trauma from throwing and those torsional or torque forces. Typically, the capsule and ligaments in this case are stronger than the growth plate. So that's why the growth plate is the weak link and fails, whereas perhaps in an adult, ligaments, capsule, those things will stretch out. Typically, the age grouping we see this in is adolescents 12 to 15, give or take, 6 months, depending on where they are developmentally and at what point their growth plates will close. And they don't all close at the same time, but this is just more with respect to that proximal humerus physis or growth plate. They complain of a dull, achy shoulder, decreased ability to throw. Often they have tenderness to palpation in this area. And again, we'll see that widening of the growth plate. And here's an example of that X-ray or slide I showed you earlier. It's often even more dramatic on the left side, sometimes even some more widening or attempts of the body to heal it through this process. And again, using the other side comparison view is helpful because, we can use that as like a normal. So again, it's what's the cause? Age, the forces of pitching. Sometimes the poor mechanics can accentuate that, and also just fatigue, whether it's too many pitches, muscle weakness somewhere along the kinetic chain, whether it's core, legs, up to the rotator cuff, or some combination of all these factors. So treatment initially is abstinence from throwing, so no throwing of any type. Try to treat the pain, taking periodic x-rays to show, hey, these growth plates are closing. So it's not like a regular broken bone, 6 weeks, you're healed, you move on. Sometimes it takes a while, it can be months, may keep them out for a season or more until they can start to go back to first throwing and then pitching. So regular throwing has to be able to be performed without pain before we can let them, start to do a throwing program where you're throwing on a flat surface, then stretching it out and eventually coming off a mound, for instance. All the while, when they're off, they're resting, maybe they're hitting but not throwing. They're working on their lower body strength, their core strength, etc. So when they're ready to kind of answer the bell and start to work on their throwing program again, that those other measures have been taken care of. Rotator cuff problems, strains, tendonitis, very common at all ages. Generally in this age group, we're talking about overuse, and again, those imbalances, bad mechanics. You can see a lot of these things are multifactorial, but generally it's just pain with pitching and throwing. They're otherwise probably asymptomatic with daily stuff, going to school, etc., sleep. But so it's not kind of classic rotator cuff disease like we see in adults, but it's more activity specific in this case. So the general treatment, and again, a lot of these points sound familiar. Rest, take away the aggravating event, make sure that they have appropriate range of motion, and that GERD or stiffness phenomenon is less common at the really young ages, but as you get older, it's something you certainly have to keep in mind. Look at the whole lower body kinetic chain, capturing that strength to transmit the kinetic energy to the shoulder. And if they learn to throw with their core and their legs, obviously it takes a lot of stress off the shoulder. And the other point really is when we treat these and approach rehab in these patients, you really have to address the scapular issues if there's any weaknesses or bad, dyskinesis or improper movement before you can do the rotator cuff. So if you kind of strengthen the rotator cuff and the scapula is not really taken care of or kind of where it should be, then some of that can be, the benefits of the strengthening can be negated. And lastly, working to an interval throwing program, which we can get you some more information about if you're interested. That's kind of beyond the scope of this talk. So principles: treat the cause, not the symptoms. Don't just, try to get rid of the pain, but also figure out where this is coming from. And this is a good time not only to go through that algorithm we talked about: rest, improving motion, strength, but also look at mechanics, because if they had bad mechanics before, they're often going to break down all over again if you don't address those. Okay. And certainly prehab, the more you can do before the season or in the off season to kind of minimize this. I think we're recognizing this across the importance of it across all sports. It's like a vicious cycle. Bad mechanics leads to injury. You lose some of your conditioning because you can't condition properly with the pain, and it can be a vicious cycle. So we want to kind of break that. And we've talked a lot about these various aspects of the recovery and injury prevention. So not only we do it to rehab people, but in the off season, kind of starting with this program and building up. So maintaining flexibility, good conditioning. One emphasis really should be that the strengthening, whether it's your lower body, your core, your shoulder, should have like a rotational component, not unlike what's depicted in that slide with the guy on the balance ball with the weight. There's obviously a lot of torque that comes into play in baseball with pitching, and sometimes even hitting, generating that rotational power. It can really go a long way in shielding the shoulder and elbow from stresses, certainly. So in general, preventative measures, particularly at the young level, good mechanics really emphasize control, the control aspect of throwing over speed, how fast or how hard you're throwing, but just getting the ball over the plate and learning kind of good habits. Try to teach them to learn to throw with their hips and legs. Certainly utilizing pitch counts. It's clearly been identified that this is important, it's good to adhere to it. And we'll try to give you a little bit of perspective and background on that here in a minute. Limit the junk pitches, the off-speed pitches or curve balls and sliders. With the youngest kids, we really want them to focus on just perfecting throwing a good fastball, having a good motion, kind of being sound in their mechanics in that respect. And then we'll show you like what pitches are appropriate at what age here in a minute. But Jim Andrews's American Sports Medicine Institute, as far back as 2001, 2002, showed that youth sports and youth pitchers specifically are more likely to develop shoulder and elbow problems if they're throwing these off-speed pitches at an earlier age than they should. And really, it comes down to skeletal maturity. And lastly, limit year-round participation. There's been such an impetus or push to play year-round. I can't tell you how often I have patients, they say, oh, I play volleyball year-round or basketball year-round. Well, baseball's a little different. We really recognize that there's some importance on downtime, shutting the shoulder down, letting it rest, and not throwing at all. So what are some of the obstacles we face in achieving these measures for prevention? Just the pressure to play year-round, the play to win. The idea that if you're not playing all the time, that you're behind. And also a lack of knowledge of what those age-appropriate pitches are, what's a safe number of pitches, and how to teach mechanics properly. Not everybody is qualified to be a coach. Just to give you a little background, in 1991 Little League World Series, so this is like 10 to 12-year-olds, 25% of pitchers threw more than 75 pitches in that year. Whereas in 10 years later, 58% of the pitchers threw more than 75 pitches. So you can see we're already kind of increasing the demands on these young arms. Similarly, this Little League World Series, 23% were throwing breaking balls in 1991, 31% of the pitches breaking balls, and 5 years later, and then 5 years after that, or 10 years from the beginning, 37% breaking balls. And an age where really we're saying these kids are too young. They really shouldn't be throwing any breaking balls. So age appropriate pitches, start with the fastball, really any age. They can master that, learn good throwing mechanics. Add the change up, fastball motion at age 10 has low stress on the elbow and the shoulder. than the knuckle curve, but you can see like curveball, slider, all those are 14, 16, 18. So they're beyond the Little League World Series age kids. That's not what's happening. This table shows pitches per game by age, and then shows that roughly everybody should be pitching twice or maximum 2 games a week, regardless of age. And just with age going up, the number of pitches per game goes up. This also shows how many pitches are recommended based on how many days of rest per age. And it goes up with the more rest you have, the more pitches you can throw on appearance, with the idea of really, if you can get 4 days rest, it basically resets you and puts you back to where you can throw, a full game or a full number that was depicted on the last slide. In general, the number of pitches is more important than the number of innings when determining these rest requirements. The maximum number of pitches allowed in one outing should increase with age, which kind of goes to logic or makes sense. Compared to younger pitchers, the older pitchers can throw a few more pitches on a given number of days of rest, which again kind of makes sense by those tables. But also, suggesting that a pitcher really should be limited to 2 appearances a week. This is kind of a busy slide that just tells you by age how many pitches per game, per week, per season, and per year. So assuming there's maybe more than one season within a year, spring, summer, fall, etc., depending on the age. But it's important the coaches and the parents really need to be in touch with the athlete. If there's any pain, you pull them. We don't want them thrown through pain. Another USA Baseball medical and safety position statement kind of hits on these points. One, multiple appearances. So not really a good strategy to have your pitcher come out of the game and then go back and finish as a position player, particularly on the outfield or the left side of the infield where they make longer throws. Showcases are discouraged. They really only lead to athletes trying to overthrow to impress scouts, commonly occurring after the season when the players are fatigued or maybe not at their peak level of performance and conditioning for throwing. Certainly discouraging in multiple leagues because they aren't felt to give players' bodies ability to recover, especially simultaneously. Again, avoiding the year-round baseball idea, there should be some periodization when the athlete has a period of active rest where they can do something else before they have to start up again. Just a little kind of comparison of mechanics. You can see the little leaguer on top and kind of how simple the motion is compared to the major leaguer down low, is really generating all this torque using his body and to generate the power as a pitcher. So improving mechanics, decrease joint stresses, kind of makes sense. Simple things that can be done in younger patients, a foot drag. So if you're a right-hand thrower, your right foot, when you're coming through, a foot drag can eliminate some of the anterior shoulder pain. Trunk rotation happens too early in many inexperienced throwers, so can lose some of the power and also so control in that case. And simple things like glove position, head position are important as well. So here's an example of good mechanics or throwing position on the left and not so good on the right, where he's kind of opened up his hips. He's lost a lot of the power from his torso and he's putting all the stress on his shoulder, and also how his glove hand like flies wide open. So it kind of opens him up and kind of loses all that like coiled up power you're trying to generate in your motion. A little more, another kind of flashback looking at professional pitchers showing curveballs. They threw their first curve on average at age 14, while now we're looking at 11 and a half. Slider 18 were historically 14 and a half for these pitchers. They rarely threw more than 75 pitches in high school, and they played other sports. So injury prevention tips. Younger throwers in general, weaker overall, growth plates are open, more at risk for injury. Delaying pitching to a later age, however, is not necessarily ideal either, because you lose some of those adaptive changes to the bony and or capsular structures that may actually aid in pitching and aid in injury prevention. So sometimes the converse being true, if you wait to delay to learn how to pitch, sometimes their arms aren't really built for it or adapted to it, and they may actually be more risk for injury. So kind of an interesting thought there. Learn to throw at an early age, that fastball mechanics, proper technique, and just excellent point, just master that. And then you can kind of go on to the other pitches as you get older and more developmentally able to handle it. Certainly proper shoulder mechanics can minimize the risk of elbow problems, and that elbow problems are a whole nother talk. You can go, that's obviously an epidemic in and of itself in throwers. So just keep these tips in mind. Throw appropriate pitch types for age, adhere to the established pitch count guidelines, emphasize good mechanics. Good coaching is important, and we want to give them tools to be better at what they do. Stay in shape, maintain your flexibility, coordination, conditioning. Pitch for only one team during a given season. Limit your showcases, probably not a good thing and may place you at risk for increased arm injury. And try to take 3 months off a year. And going hand in hand with that is really play other sports. We know that there's countless examples of NFL and NBA players who are multi-sport athletes. Similarly in baseball, there's a lot of benefits of playing other sports, learning other motor skills, different types of muscle memory and coordination that will only enhance their ability to be better baseball players or pitchers in this case. So breaking balls and curve balls can lead to shoulder and elbow pain. So try to stay away from those until skeletal maturity. Joint pain in young throwers doesn't necessarily mean weak muscles. And don't throw through pain. Strengthening through sport and participation is important. Certainly you got to play the game, you got to hit, you got to learn how to throw and develop the muscle memory. So that's important. And we're not trying to minimize that. We're just trying to avoid the excesses and overuse problems that can happen in these kids and play various sports. I think that's as an orthopedic society, that's one thing we're really stressing is the benefits of playing multiple sports. Don't be a multi-sport athlete. Lastly, a little plug, videotape analysis can be helpful, whether it's just someone who's learning the sport, coming off an injury, and certainly coming off surgery. Tom House is a pitcher or former pitcher who works with baseball players and quarterbacks, started the National Pitching Association and has a lot of good information. There's a local kind of guru that has worked under Tom House, Dean Taylor, who used to work for Ohio Health. He's an athletic trainer, had some time at Northridge, lives in Mount Vernon, and works with pitchers and all types of throwers. Videotapes, it is a great resource to help, really break down your mechanics and your motion. Another plug for a book, that Fastball Fitness, the Art and Science of Training Real Velocity. That's a good read if you're looking for some other references. And that's the end. So it looks like there's some questions here.
Yes, the first question is.
I try to power through this. I apologize.
Thank you, Dr. Comisar. The first question is, at what age can youth player begin to learn and throw a curveball?
Well, if you go off those charts, and obviously everyone's arm's developing a little different rate, they're suggesting around 14. So I'm sure maybe a little bit earlier in some kids, a little older in others. But 14 seems to be the latest information that we have.
Is there too much throwing? Pitchers used to throw much more than pitchers today and could pitch longer and more. It seems they had less issues. Can the arm get stronger the more you throw?
I think in some cases, when we're saying too much throwing, in this case, we're talking a little bit about age. So if you're talking about an adult, maybe that's true. I think in young developing arms, we're starting to question that because of some of the problems we're seeing, not only at time zero with elbows and shoulders. Growth plates of the elbows, another vulnerable space in some of these kids. But sometimes even just that cumulative throwing leads to issues down the road that we're still kind of discovering. So I think there can be too much throwing. Throwing just to throw maybe is one thing, but I guess talking about pitching's another story. So I think you can build up arm strength by throwing on the side, long tossing, things like that. But when you're talking about pitching off the mound, whether it's batting practice or game, there has to be some kind of accounting for numbers in that regard. I hope that answered the question.
Great. All players seem to have different ways they throw. How come some different throwing motions don't cause any issues?
Well, I think it's more of an independent or a personal thing. Like some people can get away with some crazy motions, right? We've all seen sidearm. There's a few out there over the years, or some guys that almost throw like underhanded or submarine. I mean, those are the exceptions. They're the freaks, not freaks in a bad way, but their bodies can take that. Whereas the average person really probably wouldn't hold up to that. So in general, that's another thing I didn't put in there, but we kind of discourage sidearm throwing, but not everybody is built to have the exact same throwing motion. And that's why there is some latitude, but there's also some kind of guardrails, if you will, about that you try to stay within for the most part, what you feel are, good practice in a sense.
Great. Do some leagues have mandated pitch limits for youth sports?
I believe more and more, I'm a little removed from that from when my kids played, but I do believe, and I remember when they were going through little league and then even junior high and high school, that they were keeping track and taking guys out, which I think is good. I'm not sure it's done everywhere, but I think it should be the norm rather than the exception.
You mentioned throwing 2 times a week. What is a good rest period?
I'm not saying twice a week just to throw. I'm saying twice a week to pitch. So if you're going to pitch in a game, that's really what that twice a week refers to. Certainly, it's healthy to get out and loosen up the arm and throw and work on distance, but to actually, pitch off a mound and throw in that manner, that's what we're trying to kind of limit and allow for appropriate rest and recovery.
Some pitchers throw sidearm and don't have any issues. What is the cause of that? I think you covered that already.
Well, like I said, in general terms, it's like anything. Some people can drive above the speed limits and be okay, and some people can't. And maybe that's not a good analogy, but in general, most comers need throw better over the top or 3/4, whereas sidearm, you have a handful of people that can do it, can get away with it. And there's also others that do it and break down or have trouble, whether it's their shoulder, elbow, or somewhere else.
How are female softball players able to throw so much more than men?
Well, there's a little bit different stresses. You think about the underhand motion. So you're not really getting your shoulder kind of cocked away from the body, and it also doesn't put so much stress on the elbow, so that the motion is in some ways has some more efficiencies to it, where it's a little more stress shielding for both the shoulder and the elbow. And as we learn more about that, I don't know as much about the softball motion myself, but I can tell you that it's a little less stressful, and that does allow for maybe more throwing and more pitch numbers, etc., without putting them at such a risk.
Do you have any stretching and strengthening programs you can suggest?
Yeah, we could. I'm trying to think how we can get that to people. There's some good stretching programs that primarily most kids don't need to stretch other than what's called the posterior capsule, which is kind of like the back of your shoulder, which is that glenohumeral internal rotation deficit we showed. There's a thing called a sleeper stretch that we could probably get some information, trying to figure out how we could do that, Heather, if we could maybe get it and post it somewhere, or put it on the website or something like that. Well, I can work on doing that. And then strengthening, there's all kinds of different conditioning programs, but I'd be happy to try to put together some things or get them and post them if people are interested. And some of it's a little bit age dependent too. If you're talking about a young thrower, youth versus adolescent versus adult, because it may vary a little bit by age.
Dr. White, if you could put your email in the chat or send me an email, I will make sure that we get the information from Dr. Comisar to you. And the final question is, how much does dropping down sidearm affect a young thrower?
Well, we think it's not a kind of throwing style we want to promote. Obviously there's guys that do it, there's outliers that make it to the major league level, but the majority of the people are throwing over the top or 3/4. So How does it affect them? I think it's harder to have really good mechanics, general throwing mechanics if you're throwing sidearm. It's also put some different stresses on the elbow and the shoulder that we don't really want to encourage, being fearful that it may contribute to either growth plate injuries in the really young throwers or potentially other types of ligament or capsular problems as they get are more developmentally mature and like the high school and college age kids. So I don't know if those things have been as studied as in depth, but I think that those are kind of outliers and not really kind of something we want to kind of teach as the mantra, so to speak, if that makes sense.
Thank you. Do we have any additional questions? Well, thank you very much for joining us. This concludes our webinar for this evening.
Yeah, thank you for listening. Thanks for bearing with me and hanging in there while we started late. I hope it was helpful. If you have more questions, reach out to us, let us know. We're happy to try to educate everybody. We all can learn from these kind of discussions.
Great. Thank you, Dr. Comisar. Our next webinar will be held on Tuesday, April 4th. Dr. Michael Canone will be speaking on total knee replacement. Enjoy the rest of your evening. Thank you.
Thank you for your time.